Hi, good morning. I'm Whitney, and I'll be talking to you guys about how IMRT changes the RTT workflow. This is my first time doing the presentation, so bear with me. If you guys have any questions or need any clarification, just let me know. All right, without further ado, I'm going to get started. I've been a therapist at Stanford for 7 years. Okay, so first we're just going to go over the general processes for therapists for 2D and 3D treatments, and then we'll compare that to how IMRT is done. Does anybody want to talk about their current workflow with patients, like your process as far as starting them to end? Volunteers. So this just shows the whole entire treatment process for a patient from consult to the actual treatment delivery. And today we're going to be going over the initial chart check, first treatment, and daily treatment. So we're going to move on to there. So we're going to go over the fundamentals for RTT workflow, the initial chart checks, and then we're going to talk about how important it is to be diligent daily for your setups and diligent at the console also. So we're going to get started with the 2D, 3D workflow. So for the initial chart check every day or before we get the patient in, we always check the consent. The most important parts on the consent is you want to make sure that it's up to date and that the patient information is correct and that the correct site is written on there. Sometimes I'll see like it says left and it's supposed to be right, or the doctor will write metastatic, but they really got to write the site that we're treating because meds can be anywhere. When you check the prescriptions, we want to make sure that the dose matches the plan. So if the doctor prescribes 600 centigrade times 1, then the plan will actually say that too. You want to make sure the energies are correct, that the bolus is on there if we need a bolus, and that the site is also correct on the prescription. You want to look over your simulation document and make sure that you understand the setup, and then I always copy the notes and bring them up so they show up in the room. We usually put that in plan parameters, and you want to make sure the physics QA has been performed. It's important to have a copy of the plan printed out so that when you do your timeout at the console, you'll have that ready and be able to check all your numbers. And also you want to just make sure that all your documents are prepared. So if you're doing paper charting, you have a paper chart ready with the dose and the fractionation written down and the setup notes and everything. It's really important to make sure all this stuff is checked before the patient gets here, because it's kind of a hard stop if you don't have one of these correct. And you don't want to treat a patient incorrectly or have them write like left arm and treat their right arm, something we can't take back. So the initial chart check is really important. So next we're going to talk about in the room, the daily setup for the treatment, what we look at. So I always start when we would do bring a patient in the room is just checking and making sure that we have the correct patient. And especially on the first day, you want to just reconfirm the correct site. Like this is you and this is what we're treating. I'll usually even tell the patient, like every day we're going to check and make sure that we have your information up and remind them that that's the most important part, is to have the correct patient. So patient positioning is really important. You want to make sure that you set the patient up exactly the same way as it was simmed, because the attenuation of the beam might change if you don't. You want to make sure you have the correct equipment. So any kind of blocks or wedges needed, bolus, and setting them up. Once you align your patient up, you want to make sure you perform the correct shifts. You've checked the light field and made sure that that looks correct. And any kind of safety check. So make sure that the gantry is not going to collide with anybody. And it's also very important to have 2 radiation therapists in the room for this process so you can check each other. I think being a team player is really important in our field, and having a backup therapist prevents many errors. So this is patient positioning. We have the correct equipment, so any blocks, wedges, bolus, visual checks. You want to make sure that you have the correct light field as said, that you've made your shifts from CT reference to ISO and checked for clearance. And then also just make sure that you have 2 therapists there for this process. I always like to just take a double look before leaving the room just to make sure that there's nothing I forgot. This is just an example of a 3D setup. So it looks like we're treating her breast. And this is a good example for when you would do like all your checks. So once you get the patient aligned and you perform your shifts, you're gonna visually move the gantry to like the medial tangent and check to see where the edge of the field is intersecting and make sure that matches the plan. And also you wanna make sure that there's like no skin folds. You wanna make sure that the flash is correct, that their chin is turned away from the field if you're doing a superclap, and yeah, and just make sure everything looks safe and ready to leave the room. So this just kind of shows you the difference between like a 2-field, how positioning is important for both treatments, but for an APPA field, you can be a little bit more like rotated. If the patient's rotated, you're still gonna hit exactly what you were prescribed versus a 3-field setup, it's coming at different angles. So any kind of rotation will kind of move the patient out of the field in some angles. You want to, and then I just noted here that, sorry, I'm just going to go back to the last one. I wanted to, so also it's important if you're doing like a breast and superclav that you check the superclav and you make sure their head is turned. And if it's mono ISO, then it's a little bit more automated. But if you're matching, you really want to go in the field and make sure that the edge of the light field matches the superior portion of your medial, matches your inferior portion of your superclab, so you don't get any kind of gaps or hot spots. Okay. And so, yeah, this is going to just show you kind of what it looks like when the patient moves out of the field, and you could see how it's a little bit more critical when you go to 3D, because then some of the edges are missing and then other areas are getting extra radiation. So you want to be even more diligent when you're doing 3D. Does anybody have any questions so far? Okay. This just shows you again the matching superclad field on the B with the medial tangent. So you want to visually confirm, if you're not doing IGRT, that the edge is matching where it's supposed to be. So no overlap, no gaps. We'll usually draw the medial tangent, the superior border on their skin. And then when we shift, we'll match it to the superclad to make sure it's abutting. And I think that's the easiest way to make sure that every day you're matching correctly. And then you could just see how you just want to confirm that the medial edge of the beam is hitting exactly where you want, along with the lateral edge, because if you're not, then you could be potentially missing or treating extra tissue. So just make sure that you're really diligent about checking that every day, especially if you're not performing any kind of imaging daily. Okay, now we're just going to talk about the RTT job at the console. So it's really important to have 2 therapists at the console. The one therapist will be the driver, and the second therapist will be helping with the timeout. So it's definitely a team playing role. Both people need to be paying attention and helping each other out, especially the second person. A lot of times it's easier to see things clearly when you're like the second person over, so you're not under the pressure in the hot seat. So for 2D, 3D plans, some of you may be still manually entering all your parameters in and paper charting if you don't have record and verify. So, but even with record and verify, it's important that every day we check our numbers, so you make sure, again, you have the correct patient on the table, you have the correct site motored up, You look at the patient in the camera and make sure like this is the correct part of our body that we're treating. This makes sense. So you want to do your timeout and then check the prescription, check that you have the correct energy. So there's 4 things you're supposed to check: correct patient, correct site, correct prescription and energy, and that the patient is in the correct setup. So that you should reconfirm before you treat. And then it's just really important that you both watch the treatment the whole entire time, make sure the patient doesn't move. So nobody should be walking around. The second therapist should also be paying attention, updating any notes as needed. Nobody should be on their phone or anything like that. Sometimes I see therapists on your phone, but you should both be very diligent about paying attention, making sure the patient doesn't move, that the treatment's going correctly. Oh, another check that I like to do is always make sure that if we're using MLCs, that the MLCs are drawn in. There was a event where one time at a center that the plan didn't bring the MLCs in, and the patient was treated multiple times because of something. So nobody checked and made sure the MLCs are in. So it is important to make sure that if you're using MLCs, that they're in. We can't take the radiation back. So our job is pretty important, and we just need to make sure that we're very diligent at the console too. All right, so again, this is the timeout that you would do at the console. You have your correct patient, the plan is correct, you're on the correct fraction. If you are imaging, you want to make sure that you're imaging as needed. So some patients you might be imaging every day, some patients might be 5. And also if you are imaging every 5, you want to update those shifts. If it's like a breast and you had a half SAM shift, you want to make sure you update your notes so you're performing that new shift every day. Check all your parameters. So the energy, the field size, the MUs. On the first treatment, the doctor will actually come and check your images and make sure everything looks correct. So it says that we should be documenting our portal images. So the x-rays should be approved. We should be taking field photos. So drawing the actual treatment field for 2D, 3D, and taking pictures of that too. So if the marks come off or something looks a little different, you can always refer to those pictures that you took and just make sure you update your treatment setup notes as needed. So if you're marking ISO, you want to document that, or if your shift wasn't exactly what physics gave you, then you want to update that. So you do the correct shift every day. So regardless if you are manually entering in your plan, you want to make sure that everything matches the plan from physics, because someone did enter this in at some time. And so even though it wasn't you, you still need to make sure that they entered it correctly. So it's really important that the second therapist reads the numbers to the first therapist and you reconfirm that all the numbers are correct. So again, it's energy, field size, the amount of MUs that you're giving, gantry angle, collimator angle. If there's a floor kick, you want to be checking that. Okay, just let me know if anybody has any questions. Okay, so this is an example. This is a plan from Stanford, and this just kind of shows you what we look at. So usually we'll make sure that we read the site. So each field has a different label. So this would be the left lateral tangent. Then we would say we have a 6x energy. On this plan, we're using MLC dynamic. And so we would want to make sure that the MLCs are actually moving during treatment. Gantry is 123, collimator 347. There's no couch kick. And then we would check the fields X1, X2, Y1, Y2, and then the monitor units are right here. So you may not have this exact plan printout, but your physicist should be able to give you a plan that looks like this that you use every day for treatment, just to confirm all your numbers. And so if you don't have an electronic version, it's good just to have this printed out with the patient's chart every day to check. All right, and then also this would list if you have any kind of wedges or anything like that. So right here it would say wedges. So you want to confirm if it's a hard wedge or a dynamic wedge, that it matches the plan on the screen, that there's a wedge. And bolus, you always want to make sure you confirm the bolus and that your putting on, removing it at the correct time. Okay, so now Alina's gonna do a Zoom poll.
All right, we're gonna give it 20 more seconds.
Yeah, I could see him.
All right, great.
Okay, so having treatment. So the question was, having treatment plans automatically updated for the treatment console makes me feel more relaxed. I can trust that treatment delivery will be correct. More anxious. I have to do extra checks to make sure that treatment delivery will be correct. And neither, I still feel the same about checking that treatment delivery will be correct. And I think what's important to understand is, even though the plan is automatic, it is important to check your plan every day and be diligent. So just make sure that you're just as diligent with automatic uploading as you are with manually typing in. Okay, gonna move on to the next slide. Okay, so now we're just gonna go over how the workflow changes using the IMRT technique. Just take a look at my notes here. Okay. So there are many ways that IMRT actually makes our job easier. One of them is that we do not have to place lead blocks in the machine. I'm sure many of you have used those blocks and know how physical that and draining that could be to go in and take them out and put them in. Also, there's also a lot of things that are more automated and computerized, and we have electronic records. But we just want to emphasize that computerized automation does not remove checks, but adapts the checks. So we're still diligently checking everything. It's just not as physical. You're not like typing the numbers in, and you're not manually putting these blocks in, but we are still making sure that our numbers are correct and that the MLCs are actually doing what they're supposed to be doing. And then also, I'm not sure who's using cassette films versus IGRT, but it's a lot easier to everyday film with OBI or MV panels, where you can reconfirm and make sure that you're on the correct area of the body. Our job is getting a little bit less physical, but because the margins are becoming tighter because of this automated process, it's important to be just as diligent. So we're just going to talk again about initial chart checks. So how the initial chart checks for IMRT. So we're still checking to make sure the patient has a consent, make sure that the prescription is correct, simulation document, all of that hasn't changed. The physics QA is more intense. They have to do a lot more double checks and run the plan before we do any kind of treatment. We still want to make sure we have a copy of the plan, just like we would for 3D. We want a copy of the plan and that we're checking our numbers. And we want to make sure that all of our documentation and notes are up to date. Our patient setup is correct.
Really quick, you have a question.
Okay.
Someone asked, are you saying there's no hard copy documentation in IMRT?
No, we do want a hard copy. So you would want, just like with a 3D plan, you would want to have a printed out plan, and it should be basically look the same as a 2D or 3D plan printout that we should be checking every day. Okay, and for daily setup, how it changes for IMRT. So the patient positioning is the same. However, your visual checks are going to be a little bit different. For example, you're not going to have a light field that you're going to draw and that you're going to check every day. So what do you check instead? You would check and make sure that you're going to make sure that the lasers are actually on the correct treatment part of the body. So you want to line up to your CT references and make sure you make the appropriate shifts and verify that you've made these appropriate shifts by thinking like, well, what am I treating? Does this make sense? So if you shifted 7 soup and it says T7, like, are you in the T7 range? You want to make sure that that looks correctly. And also a lot of times we will mark the ISO center. So we'll have CT ref marks or your tattoos if you guys are tattooing, and then we will mark our ISO center. Some facilities will do the ISO center with a completely different color, or we usually just circle our ISO, and that kind of helps you defer the difference between a CT ref and an ISO mark. And it just makes it a little bit easier every day. So you're confirming like, yes, we're on the ISO, versus when you do a CT ref and you shift every day, you're leaving a little bit room for error. So just make sure whether you're going to the ISO mark or you're doing your shifts, you're reconfirming that this is the correct body part. This is what we're treating. And that makes sense. That's where the lasers are at. You're still going to make sure everything clears, check for clearance, any kind of collision avoidance. And then your patient positioning actually must be more accurate with IMRT because of the way the beam is. The margins are a lot tighter. So any kind of variance could change where your PTV is hitting, as well as critical structures can become closer or into the treatment field because the margins are so tight. Okay. So again, this just kind of shows you how the patient being moved, you could see the beams, and then moving moves different areas in or out of. So you'll get like a cold spot if the patient's like too far to the left or to the right, versus with an APPA field, you're pretty much going to hit everything you need to a degree. So with 2D treatment, it's not as critical to be like if the patient's rotated or anything. 3D becomes more critical. But then as you go to IMRT, it's the most critical, like a rotation or any kind of differentiation in the patient setup can change the beam entirely, and your treatment area may not get the dose it needs, and a critical structure can get more dose depending on how the patient is positioned. So you could see like this kind of looks like the spinal cord is being blocked out. But if the patient were to be shifted, then the spinal cord is going to be getting extra dose, which we don't want, of course. So we want to make sure that we set up the patient exactly like the CT scan because of this, because it's so much more critical now. Sorry, I just want to go back a little bit because I skipped a couple things. So for this, we're also still checking to make sure that if the patient has bolus, the bolus is in the correct spot. Any kind of wedges are there. So just the inside of the room is very crucial, even with IMRT, or especially with IMRT, because we don't have a light field to look at or anything. So you want to make sure, especially if you're not using IGRT, to confirm that everything is correct before you step out. Okay, sorry. So we'll go to, so we looked at this patient positioning. Okay, so this shows you an example, a patient getting set up in the room, and you can see how far off they are. So without using IGRT, they wouldn't be making this shift, and all the organs would be shifted into a different place. So this particular patient has like a large loose belly, and so the marks are not as reliable. And so if you can image daily for IMRT, I highly recommend it because of this scenario right here. Like your marks don't always tell you what's going on inside. And you could see, so the blue in the image is actual treatment area, and the orange is the DRR. So the plan is shifted quite a bit. And this is the PTV. So, I mean, that's about maybe 3 cm difference, 3 to 4 cm difference off. So it's important to be diligent in the room. And also if you are using, we always film all of our RMIT patients daily. And this is one of the reasons why. It's because something can look on, but when you actually film, it's pretty off. So if this was a 3D plan, you'd probably have a significant amount of margin and it wouldn't be as big of a deal. You'd probably still be hitting the PTV. But with an IMRT plan, the margins are like 2 to 3 millimeters. So this would not be acceptable. So we're asking how daily setup changes for IMRT. So even though you're not checking the light field, you're still doing a visual check. You know, you're making sure your patient's set up the way they're supposed to be, confirming with your notes, and then you could also check your pictures that you took on the first day, confirm that the ISO center is placed on the correct part of the body. and it matches what you did before. You're checking your gantry clearance, making sure everything clears. So some machines have rapid arc where the gantry is moving. So if it's a full arc, you just want to make sure that the table is not too far over and that the gantry will clear. Same for static IMRT fields. You just want to make sure that all the angles clear. It's important to check that before you start, because if you line the patient up and treat the patient like mostly, and then you realize, oh, this doesn't clear, then now you're moving the patient in the middle of treatment to get it to clear. So you want to make sure everything clears before you take any x-rays, before you step out of the room. And this just says, again, patient positioning must be more accurate, more frequent image matching will be covered. So they're going to go over image matching in the next session, but daily imaging is preferred for IMRT. And if that's not possible, it's super important to be really diligent and make sure your patient's in the correct position every day. So like for the patient with a belly that moves a lot, you probably want to get mark like higher up too, just to reconfirm your left to right, maybe like something near xiphoid or on their sternum, just to get a better right left mark. Okay, so we're gonna go over the next slide. So what we do at the console for IMRT. So again, the IMRT requires more frequent imaging. So usually daily imaging, and then paper charts versus electronic charts. So again, RTT1 is driving, they're calling out the timeout. So you're saying like, this is the patient, this is the dose, we're gonna image this. You wanna make sure that you're always watching the patient during treatment. And the second therapist needs to be documenting everything. So like recording your timeout, making sure that the first therapist is paying attention. But again, you're also going to check your entire plan, which I think we're going to be talking about in the next slide. They just say to talk about electronic charting. So whether you're paper charting or charting electronically, it's just important that you still make sure you do all the steps so that you're always making sure on the right fraction, you have the correct plan, correct field, most important, correct patient. And then also just, yeah, if you're doing IMRT and you have OBI, I would definitely recommend imaging every day your patients, making sure they're lined up. And if the patient looks off, like their shoulders need to go to the right, just remember your margins are really tight. So it's always a good idea to adjust the patient and make sure that they're lined up to match the CT scan. And the second therapist should just be confirming, like, this is what imaging we're doing today. So whether it's OBI images, MV, you guys should make sure you're both on the same page before you start treatment. And then also making sure that the first therapist, the driving therapist, is paying attention, watching the patient. If the patient moves in this kind of treatment, again, they can get, their PTV will be shifted and a critical structure can get irradiated. So it's even more important that the patient is really still. And then this just says like, we want to make sure that the MLCs are moving. So on this screen, you could see up here the MLCs. So if you're doing IMRT, you want to make sure that those are actually moving during treatment and drawn in. So one therapist could be making sure, okay, the MLCs are moving, maybe looking back and forth at the patient, but the second therapist should also be checking, are the MLCs in? Is the patient being still? Do they need us for anything? Okay. So this probably looks pretty familiar because we just looked at this for the 3D plan, but this is an IMRT plan. So you're basically going to be checking the same thing as you would for 3D. You're going to check and make sure you have the correct field name, the energy. You're going to make sure that the gantry rotation is correct, that your collimators are correct. You're going to check your X and Y jaws, and then you're going to check your MUs. The only thing that probably you won't see in IMRT is you're probably never going to see a wedge because you have MLCs moving. So, but you could see that this is a VMAT plan, so your MLCs should be moving all the time. Sometimes they do a conformal arc, and that would not be considered IMRT. where your MLCs don't move. So anytime VMAT is there, your MLCs, it should be moving and changing the beam to make sure it goes like this. Okay, so how does transitioning to IMRT affect the department? So IMRT can affect the department in many ways. The treatment times will become longer because a lot of times you are adding things like filming every day, cone beam CTs. Your precision is more important. So you're probably going to go in and adjust the patient more often than you would if you didn't have IMRT. For physics, it's definitely more demanding for them. They have to do a lot more QA and second checks to make sure that the plan is going to deliver exactly how they planned. So you must have a robust QA program in place. How will new technologies be implemented? Give me 1 second. And then with IMRT comes other things like cone beam CTs. So you'll be doing a cone beam CT, which is like a 3D image guided imaging that you'll overlay over your CT scan to make sure that everything is attenuating correctly. You can also see if the patient's weight has changed dramatically and they possibly need a new plan, because with IMRT, it's more important that if their weight changes, that they get replanned. So everybody should be trained for IMRT and image guided and have a good understanding of how the IMRT affects the department. Sorry, I'm just reading this note real quick. Okay, so in conclusion, how does the workflow change when using IMRT? So for RTTs, electronic documentation will be implemented using IMRT, but so we won't be manually entering in the plan parameters, but every day we will still be making sure that we're on the correct plan, you have the correct fraction, and you're going to make sure that all your numbers match the printed out PDF of the plan. We don't have to use heavy blocks with IMRT. The in-room part is a little bit different, but it is still, if not more critical, to make sure that your patient is set up correctly. You just don't have the light field, so you want to make sure that your lasers are actually lining up to the ISO center, the area of treatment. And imaging daily is highly recommended. If you don't have OBI, maybe like an MV every 2 to 3 days versus once a week. And I would do an MV orthogonal pair, so like an AP with a lateral, because you need to get both angles to make sure that you're on in all aspects. So at the console, pretty much everything is the same. You're still making sure you have the correct patient, the correct parameters, the correct fraction. If there's any bolus, you're making sure that's on. The therapist will always ask themselves, how do I know that I'm delivering the correct treatment? And that's one of the things with IMRT is it's not, you don't get this visual like in the room, like this is where the beam is going, because it's modulated. So you're really relying on that in-room diligence of setting the patient up, as well as your imaging. Like you're trusting that if you line this patient up exactly the way the CT was done and your images are matching the way they're supposed to be, that the radiation is going to go exactly where it's supposed to. Okay, does anybody have any questions?
I see that there's a couple of questions in the chat. The first one is, what exactly is timeout?
Okay, so a timeout, that's a really good question, is something that you do before you treat the patient. So before you beam on, you're going to take a second, and we call it a timeout because it's just like everybody gets quiet and listens and make sure that we're all on the same page here. And you're going to say, like, this is the patient, you know, Mary, we have Mary on the table. And then you're going to say, so you confirm 4 things. You're going to confirm your patient name. So you have the correct patient. So you look at the name, you both look at your screens, make sure you're on the same page and that's the correct patient. You're going to correct and make sure that you have the correct site so that we're treating her right breast. So you both say, yes, we're on the right breast. Like you have your planet that says right breast, the screen says right breast. You look at the patient, are we treating her right breast through the camera? And then you're going to check the prescription. So make sure like this is fraction 5 of 25. She's getting 200 centigrade per day. And then finally, let's see, patient, site, prescription. And then lastly, she's in the correct position. So you want to make sure that she is in the correct position. Her both arms are up, her head is turned to the left. So all of that, that's your 4 every day before you treat a patient, you should be performing this timeout. So it's correct patient, correct site, correct prescription, and correct position. That's a really good question. Thank you for asking.
All right, thank you. And then the next question is, with all the checks during treatment, kindly talk about radiation protection to the patient.
Okay. So because we have internal lead shielding, the MLCs, we don't have to do like put lead aprons on the patient or anything because the energy is so high. So it's mega voltage. So not like when you go to the dentist office, you have to put an apron on and you get the scatter. The energy is more direct. And so we don't put any kind of lead shielding on the patient. It's all internal. So you can tell the patient like we're blocking out the beam with this internal shielding. That's a good question too.
All right, thank you. Then someone else asked, how often should my images be done?
If you're doing IMRT, I would say that if you have OBI, I would say daily if you could. This is always up to the doctor's discretion, but most facilities have a policy where if you don't feel comfortable, you can always take an image, which I think that's best practice. If you're doing a 2D, 3D plan, at least every 5 treatments, you should be filming.
Great, thank you. And then someone asked if you could briefly explain IGRT again.
Okay, IGRT is image guided radiation therapy. So that means that every day, basically, we're going to take a film and make sure that we're correct. So we're not just visually looking at the light on the patient and confirming and treating. We're actually going to take an image and apply the shifts. Older systems will make you like go in the room and manually shift the table. The newer systems, you just would apply the shift and it would shift in the room. And if you have a large shift, like we have a policy at our department, if your shift is over 1 cm for pretty much any part of the body except for head and neck, you would refilm. You would take one more film just to confirm everything's lined up. If it's a head and neck, we do half cm and we refilm. So image guided radiation therapy is basically like every day you take a film, you take an orthogonal pair, and you make sure that everything looks correct before you treat.
Awesome, thank you. And then someone asked, why is there no field light in IMRT?
That's a good question. So there is no field light because the way the beam comes out, the MLCs are constantly moving, so they don't display like a one field light. A lot of times IMRT is at different angles to either rapid arc, where it's just a complete arc, or it's just like from like posterior. So you just don't get a field light because the leaves are constantly moving. Let me see. That's why image guided radiation is so important. Let me see if I can find a picture. So you could see how in this, the beam it's not just a straight field. It kind of changes. So the way IMRT works is, this is a arc plan. The radiation is adjusted from all directions so that you get this intense amount of radiation to the PTV, the treatment of interest, and the rest of the area, like the femoral heads and stuff, is blocked. So they get a small amount of radiation. So this is good for the patients because they get less side effects. We are able to give a higher dose to the cancer area, and the rest of the critical structures are getting less radiation. So because of the way the MLCs are constantly moving, you can't see the light field. It's kind of, I wish I had a video to show you, but it's kind of hard to, but you'll see that these are always moving when you do IMRT. So you don't get a solid field versus, let me show you that breast plan. Versus this breast plan, the beam just goes straight. So you're actually looking at this light field to confirm like this is where the radiation's going. IMRT would go all the way around. So you don't get this nice light to look at. This. Okay. I hope that makes sense.
All right, thank you. And then the next question is for IMRT/VMAT, what are the challenges your team faces every day compared to 3D CR?
I think for IMRT, it's more challenging just because the margins are so tight. So especially for like a head and neck patient, it's just really important that their position is spot on because there's so many critical structures that if their head is rotated or their spine is a little off, it will throw off the radiation. So we are more focused on making sure the patient is positioned correctly, like very diligent. That's why we film every day and just make sure everything's lined up exactly the way we want. So you spend a lot more time making sure the patient is correct in the correct position. Like you're more diligent.
And now the next question, how do you verify the treatment field during treatment?
So during treatment, though, you're only going to be checking the numbers. So on the IMRT plan, you'll check these same numbers, and then you're just going to make sure that the MLCs are moving. There's no way for us to actually make sure that the MLCs are moving the appropriate amount. That's why the physics does their second check. They're very diligent about that. So we just make sure that we have the correct plan motored up. Let me show you. So we're going to make sure that this plan is motored up and that all these numbers match and that this is dynamic. And if this is VMAT, we need to make sure, most importantly, that the MLCs come in and they're moving. But as far as the MLC position, we're not confirming that every day. They're constantly moving. So there's no way. Yeah. So basically we're relying on physics to do their part to make sure that that's correct.
All right, looks like we have 3 more questions. Someone asked, we usually take MB the first 3 days. What's your advice for IMRT and VMAT?
So if you don't have OBI, I still would recommend an orthogonal pair. So doing like a lateral and an AP or PA. And I would recommend doing that daily for any kind of IMRT plan.
All right. And then someone asks, is there a limit to how many patients a therapist can attend to a day?
As far as I know, there's none. There's no limit.
All right. And then last question for now. Can you briefly explain field and field in relation to IMRT and VMAT or rapid ART?
Oh, that's a good question. So field and field is kind of like IMRT, but the MLCs do not move while the beam is on. So it would be like, a lot of times you'll see it for breast patients. They'll do like a field and field. So they'll do like a full field, and then all of a sudden the MLCs will come in and treat a smaller area, maybe like extra dose to the cavity. So the beam will actually stop, the MLCs will come in, and you'll treat a smaller area, and then you'll be done. Versus if it was an IMRT breast, the MLCs would be moving the entire time. So there would be, like, if the MLCs are moving during treatment while the beam is on, then that would be VMAT or rapid arc. If the gantry is moving, it's rapid arc. But if the gantry is not moving and the MLCs are moving, then that's IMRT.
All right, and it looks like we had another question come in. Fairly, how many hours a day should a therapist work treating patients?
I think it's really important to listen to your body, and fatigue is really important. I did a 11-hour shift on Thursday this week. So I did from 7 a.m. to 7 p.m. So, but I think after a while, there's no rule of thumb, but it's safety. You're taking care of patients. Radiation is something you can't take back. And so if you're tired, you're probably not you're putting the patient more at risk. So it's really important to listen to your body. And if you feel like you're working too many hours, then you probably are.